chance to talk to you about a topic I think is very important, and we'll have actually other speakers, and we will hopefully get more understanding about this issue of colon cancer and the word screening. My talk today is to talk about the modality. And first I'm going to talk about screening. What is screening, why we need it, and who should be screened, what are the modalities approved, so how we screen, and how do we choose the best one. So what is screening? Screening basically means that you need to detect a condition early, before the disease. So it's a pre-disease condition, before the patient gets the symptoms and the signs. And that makes sense only when you have an intervention that you can apply, so this would change the natural history of this disease that you are looking at by avoiding its morbidity and mortality. While on the other hand, we have the term surveillance. That means the patient already has a condition, which is in our case cancer or polyp, and you want to prevent recurrence of this condition. We're talking about here screening only. So what's the story of Dr. Faisal will be talking about the issue of colon cancer here in Saudi Arabia, but I'm just going to show just a couple of slides. We see, if we go to the data from the Ministry of Health, you'll see that among the 5 most important reasons for people to die here in the kingdom, cancer is one of them, and it's actually number 5. And if you spell out the types of cancers that we have here, you see that number 1 in men, it's colon cancer. Number 3 in females is colon cancer. And if you look at what's happening over the years, it's clearly that the incidence is growing in the last, from the study, from 94 to 2003, they're almost doubling of colon cancer, while worldwide it seems that colon cancer is becoming less and less. So is colon cancer a good target for screening? The theory, we need to understand how colon cancer happens. The majority of colorectal cancer progresses from normal mucosa into small adenoma, large adenoma with villus component, then high-grade dysplasia, then becomes cancerous. And that's in about 70% of sporadic colon cancer, show multi-hit process that we talked about. So if we can intervene anywhere before this stage and have a modality that we can prevent this from happening, then we can achieve this screening target. However, we have to realize also there are different pathways for colon cancer, including the mutations leading to microsatellite instability and the APC gene mutations, and the most recently talked about, the serrated adenoma pathway. Here in the kingdom, we don't know exactly what's the percentage of each one of these, and that's something also need to be clear to us when we talk about screening. So how to screen? This will be the rest of my talk. I'm grouped them into 3 categories. The first one is by means of seeing the colon either by colonoscopy, FLEX-SIG, or by capsule, or by using fecal testing, or by using some imaging modality. Fecal occult blood testing, it's done. We all know how to do it. The patient has to give 2 specimens from 3 consecutive stools, and it does include a lot of dietary restrictions, and also they should be avoiding aspirin and NSAIDs. The evidence for that is really good. The evidence shows that there is reduced mortality by 33% at 13 years of age, and this is from the study that I'm referring to here. The problem with it, for every 50 patients with positive tests, 1 will found to have cancer. The rest, there's disadvantages with false negative and false positivities. And those patients, when it's false positive, then you have to still do colonoscopy, and still you have to subject them for invasive tests that you initially thinking by doing just occult blood, you're avoiding the invasiveness of testing. Now, it's very important that you realize that the current test that we're using here, it's kind of obsolete. Now, it's more recommended that we use the newer version, the Immunochemical sensor, and that has a better sensitivity for picking up polyps and advanced neoplasia. What about the other fecal testing? This is a better testing because it's more sensitive, and it's by fecal immunochemical testing, you check for the whole hemoglobin, not just the heme, like the previous way of testing. And this has a better sensitivity, and more importantly, it's easier to administer because it does not require any dietary restrictions, and you expect to have more compliance than telling the patient you have to give 3 consecutive stools. But the problem is that, again, sensitivity may decrease with delaying testing. And it's more expensive, but if you look at the cost effectiveness, it does make a little more sense that if we have this available, it will be more better, because it will have more sensitivity to pick up neoplasia. What about imaging? There are different ways of imaging the colon. And previously, we used to talk about double contrast barium enema, but really this is kind of fading away in favor of CT colonography, because still you can miss up to 39% of polyps and 15 to 20% of cancer. So it's not a really great test. Not to mention the discomfort when you put air and dye in patient's rear end. So it's not a very favorable test. Going down to the third ways of testing, which is putting scopes. I'll leave the CT colonography a little late, so we compare CT colonography with virtual colonoscopy with optical colonoscopy. Sigmoidoscopy was very commonly practiced, a way of screening, if you go back 15 to 20 years ago. And the problem with that is, as you expect, you can still miss right colon lesions, which can be anywhere between 33 to 65%. And they commonly, this is more, seems that women tend to have more lesions on the right side of the colon. And really, when you think about sigmoidoscopy, it's like doing mammography in one breast. Though you can advance or increase the sensitivity by, if you find a polyp on the left side of the colon, then you may bring the patient later on to have full colonoscopy, and then you may increase the sensitivity by 20%. What are the advantages? They used to think it's a good test because it requires less vigorous preparation and can be done by many healthcare workers. Even nurses can do this test. It is not as intense or requires a lot of training. But still, in one study showed that up to 10% of patients, they were not able to finish the flexible sigmoidoscopy because either preparation or even the training issue is still important in sigmoidoscopy. The evidence for sigmoidoscopy is very good, actually. There's a clear evidence that there is a reduction in incidence of colorectal cancer by 32% and mortality by 50%. But you still have to repeat it every 3 to 5 years. Colonoscopy, we will talk about, it's a 10-year test. If you combine this sigmoidoscopy with occult blood testing, you may also increase your sensitivity. What about colonoscopy? It's the gold standard. It's the preferred way by the American College of Gastroenterology for screening for colon cancer, because it's the best, the most sensitive that we're aware of. It gives means for prevention. When you find polyps, you can remove those polyps, and it can be cost effective, especially if you apply it every 10 years for normal population, and if you adhere to guidelines in terms of when you repeat the colon cancer screening and surveillance for polyps. The disadvantages, we're always afraid of complications, perforation, bleeding, that can happen up to 1 in 1,000. And the problem with that, it may take time from the patient and the physician, so it's a labor-intensive kind of way of prevention. And it becomes really problematic when you bring a healthy patient, no problems, no symptoms, and then by the end of 15, 20-minute procedure, there's a complication with perforation. So that's really a big issue. What about the evidence of its use of its help? From the natural polyp study, and after follow-up of 16 years, it was shown that there is 53% reduction in colorectal cancer mortality by removing those polyps that are found on colonoscopy. And this is not randomized study. This is more of a comparison to historic controls, general population. Completed colonoscopy was associated with decreased death from left-sided more than right-sided. And this is more than one study showed the same thing. And they are coming both from Canada. And both studies actually were criticized heavily about the methodology, about the training of the operators, about following quality indicators of colonoscopy, which I think Dr. Sania will be talking about the problems of when we apply a method of screening, what are the problems that can arise in our face. On the other hand, there's another study that came from Germany, and that study showed by applying colonoscopy, you could still decrease the incidence of both left-sided and right-sided colon cancer. Yet the effects were more pronounced in the left-side colon cancer. And it's not so clear why it's the issue. Is it because we are not reaching the cecum in good percentage of time? Is it because the preparation need to be addressed and you have better preparation? Is it different total pathway of colon cancer, especially serrated adenoma and HMPCC? It's not so, which sometimes take shorter duration for the process to become into cancer. The sensitivity of colonoscopy for polyps among different studies is pretty good, and this is really the best, most sensitive test, especially for smaller polyps. And when you apply it every 10 years, it becomes really attractive. What about the CT colonography? The issues with CT colonography, previously patients were getting preparations, but now you can digitally subtract the labeled stool and save the patient the preparations. So that's an advantage that many patients will like. It's proposed that if you want to apply this condition or this way of screening, that the patients, when they are prepared, that you should proceed right away to colonoscopy. Though it's easier said than done, because you have to have the colonoscopy suite open, the endoscopy suite open, and you have to have all sedation. Patient has to have someone with him, and it's not as easy to apply both colonoscopy the same session. But if it can be done, that would be the best way to do it. Sensitivity for picking up lesions, larger lesions, more than 10 millimeter, is pretty good and very comparable to optical colonoscopy, but it does not do as good as smaller lesions. Some people may say, well, smaller lesions are not as important as lesions more than 10 millimeter. There's a study from Netherlands that compared optical colonoscopy with virtual colonoscopy, and although sensitivity for optical colonoscopy was better, however, at the end of the day, there are more patients opted to do CT colonography, the virtual colonoscopy. So we ended up doing the same number of prevention or polyp removal by using either method. This advantage of CT colonography is that you are giving patients X-ray exposure. And there is still a high miss rate for flat lesions and for serrated adenomas and depressed lesions. And more importantly, and this can be really confusing, that a lot of time you may pick up something else, not necessarily in the colon. Some incidentaloma, some lesion in the adrenals, and what do you do about those lesions in a completely healthy patient can be really problematic and may subject the patient to a lot of testing. CT colonography still at this point is more costly and less effective than other screening strategies, so it's not a preferred method, but I think it's still one option that we can look at and discuss with our patients. Going into the third way of screening, which is fecal DNA test. Fecal testing, it's not available commonly. Actually, the only test that was available in 2012 was pulled out of the market, and it's not available for us here in the kingdom. Sensitivity also ranges among different tests, but overall it's not a bad sensitivity. But listen to this. You have to submit the whole bowel movement in ice to a special centralized lab to have the test done. So it's really, from a logistic point of view, it's not an easy thing to do. And it's still expensive, and even more expensive than colonoscopy. One word about capsule endoscopy. It's just fancy, really, in terms of how good it works. It's not very good, and really in the States they have not even approved it. You see it more in Europe, practice, because it's easy, but you have to give the patient a lot of preparation, even worse than colonoscopy, because you cannot clean. When we do colonoscopy, if there's a suspicious area, you can clean, wash, and have a better look. But with capsule, you just have to depend on your luck that you're seeing well, so you have the patient really have a very good preparation. There are other technologies, like using endoscopy, narrowband imaging, magnification endoscopy, that's a supplement to colonoscopy. And this is still, we talk not for wide practice, not for everybody, maybe in a subset of patients. What about the new kid, actually the new dog on the block? There are some scientists saying that by training dogs, they can sniff for you cancer, and some of them saying that the sensitivity can be up to 98%, and we may soon find ourselves out of business. But this is still not, we need a lot more literature on this. This slide I'm just show because some of us are interested in economics and how much we pay for different testing. And this study shows that really by adopting colonoscopy, although occult blood testing is cheaper at the beginning, but at the end of the day, the cost per life saved is better when you opt to use colonoscopy, because you have better sensitivity test, and that will really, at the end of the day, you'll be saving money. One word about who to screen. We have different options now. We talked about the menu. Which one do you use? Really have to look at the patient. What kind of patient are we dealing with? If you have a high-risk patient, like those who have previous polyps or family history of colon cancer or inflammatory bowel disease, they're probably best screened and looked at by colonoscopy. More so important is average risk patients. Which one do we choose? And those patients are anyone above age of 50. So if you have patients, asymptomatic patients, they are less than age of 50, no family history, does not need even any screening. But if you have more than 50 years of age and there's a positive family history, then you try to group the patients into one of three categories, which is the high category, that fits into HMPCC. You know the rule of 3 to 1, 3 family members, 2 generations, 1 first degree with cancer, of colon cancer, or similar to colon cancer like uterus or ovarian. And those patients need special, beyond the scope of my talk today. But if you have positive family history but not as strong as to fulfill the criteria of HMPCC or FAP, then for those patients you start screening at the age of 40 or 10 years before the youngest patient diagnosed in the family. Or if you have first degree at the age of 60, then there's probably average risk. Some people say start 40, others say 50. I'm not going to go through the slide, but just to emphasize one issue. Because when you screen, you need time, you need resources. It seems that a lot of resources are being spent on surveillance. And this is why, just recently, a few months ago, the 3 major societies in the States gave update on their recommendations when to look for polyps later on. And they extended the duration for a lot of those patients to give more space and more time for those patients who have not been screened to look at. So this really concludes all the methods. I talked about those methods in some more details, but this slide shows the different methodologies and the sensitivity, specificity of those, the complexity from being the lowest, but everything comes with a price. It's easy to do, but not as much good results eventually. I'm just going to spend 1 minute on the ACG guidelines. The ACG recommendations from 2009 suggest that the best screening test is really colonoscopy, and it's preferred because, as we said, it's preventive as well as you have the method to remove those polyps. And they're recommending age of 50, unless the African American 45. This is all in the States. I'm not talking about what we do here. We will listen from the next speakers what should be done here in the kingdom. And they are really giving differentiation between 2 types of testing, either cancer prevention by polyp removal or early cancer detection, and that is done by stool testing, and the best stool testing is the fecal testing. Alternative ways, flexible sigmoidoscopy or CT colonography. So in the summary, what do one of those choose? Which method we should be choosing? We should look at the patient risks. We should look at our resources, how many times, how many endoscopists, how many endoscopy units we have, what about the cost, how much the patient is going to be paying, and what the patient preference, education. We struggle still here that if you mention screening to any insurance company, they will give a heart attack because they will not approve any testing for you. And we have to look at our data, how common, what's happening to our colon cancer, what's the pathway for colon cancer, and how we can prevent it, because it's really becoming a more widespread problem. Thank you, everybody.